to be able to provide a series for people who actually plan education courses here, just to help everyone understand what some of our thinking is in the CME office around the structure of curriculum planning, as well as some of our hard requirements for accreditation. So that's why we designed this series, to kind of go step by step through the major stages and pieces of curriculum development. Last week we did a session on discovery, which is really how to find the evidence you need to write a good evidence-based needs assessment. And today we will pick up after that with construction, which is really how to focus on your learning objectives. And believe it or not, there is a science to mapping through this and aligning. So we'll go through that in detail. Again, the series covers a lot of different things, but today we will talk about what is a measurable, achievable, and practical learning objective, so that you'll have those 3 tools in your toolbox to think about when you're writing your learning objectives. So just to introduce who we are, I'm Rob Martin. I'm the Assistant Dean for Continuing Medical Education in the Office of CME Academic Affairs. We now embrace not only continuing medical education, but continuing ed for all professions, with the exception of nursing, which has its own office, but we work in close partnership with them to accredit nursing credits for many of our multi-professional activities, as well as medical credits for nursing activities that are for a mixed audience. And Jack Scott joins me. I'll let him introduce him.
As you can see, Assistant Dean here also too, and I haven't had a chance to meet you all before, but so what we're doing constantly here at Winthrop is advancing educational excellence and teaching excellence especially. And whether it's for our medical students, for our residents, for our faculty, for our other health professionals, but also for continuing professional education too, when we do that. So there are a number of accreditation standards we have to adhere to, but still the educational principles are to be able to meet the needs of a learner. The learners come first. And so how many times do we organize a course, a level of instruction that's really for our benefit? It's something we want to teach, but it's really about what learners have to do to learn. And so some of these aspects will certainly help you, as we did last week as well.
Thank you, Jack. So could we just do a quick round of introductions of you all? Go ahead.
Hi everybody. I am Christine Guarneri. I am a nurse. I have a master's in nursing education, so I understand the education piece, but really here at Winthrop, I'm an oncology nurse, and I work with the medical oncology department as well as affiliated practices, colorectal surgeons groups, and the surgical oncology, Dr. Allendorf's group. So I've been involved in 2 CME programs. One of the programs I tried to write the paperwork myself or fill out the application myself, which was difficult. And it's hard, I think, if like I was doing it for the first time and I really stumbled, and I would send it to Rob and he would say, check this out, and I would send it back and he'd say, okay, try that, and you know what I mean? So I'm happy that you're having this, because I'm running another CME program in November and another one in March. So I'm trying to gather up all my paperwork now and work that out.
This is all good timing for you.
It's perfect timing for me.
Yeah, you be more self-directed in doing this.
I would like to have more people helping me.
Yeah,
So,
yeah.
but this is great for me.
Great.
So.
Dan.
My name is Dan DeSimone. I'm one of the 2 supervisor of athletic training services over in Winthrop Sports Medicine, over in the outpatient physical therapy office on Franklin Avenue. Like her, I'm here new. I did 2 CME events at first I really had nowhere to start. I didn't know what to do. I went back and forth, and I reached out to other people too. So I'm just trying to get a better grasp on how to run it, how to set it up, and do a better job.
I think the majority of us have learned by taking the plunge as you did and as you did. So hopefully this series will make the plunge less of a cold, bracing plunge. But Peter?
I'm Peter Sandri. I'm the CME specialist in the Office of Academic Affairs. I've been here just short of 4 years, and I need to learn this just as much as you guys do, because since we're short staffed, which is basically Rob and myself, I may have to take on more stuff. So a workshop like this would be very beneficial for me as well, especially for like grant applications and other and accreditation purposes too, especially when it's time for us to get audited by the ACC.
Diana?
Diana Richmond. I'm a perinatal sonographer. I work with maternal fetal medicine across the street in the hospital. I've been a sonographer for 20 years. I've been doing MFM for 13 years. And my doctor should would like me to start taking all the knowledge that's up here and start teaching the new generation. So,
Did you say stenographer or sonographer? Sonographer. Okay, good. Thank you. Well, welcome all. So we have nothing to disclose, Jack and I, in the spirit of financial disclosures for CME, nothing to disclose. We want to go over what today's learning objectives are. And so we're going to discuss, first of all, Bloom's taxonomy of measurable verbs. This is a really great resource for tuning up your learning objectives and saying, is what I want to accomplish and its parts, are they going to be measurable, and does my choice of words and action verbs imply measurement? If it doesn't, it should, and that's where Bloom's taxonomy is a great resource for that. We're going to also, during the workshop session, maybe look at some non-measurable learning objectives and how to revise them to improve measurability. We're going to analyze measurable learning verbs according to observable action. And we're going to relate the measurability and observability to clinical practice changes using a fairly recent framework from Donald Moore at University of Tennessee. So those are our objectives. Today's agenda, we're going to do a quick 5-minute review of last week, go over what is a learning objective, how can we objectify learning according to our 3 MAP tools, measurable, achievable, practical. We'll go over what exactly Bloom's levels are, the verbs, what is achievable behavior change according to Dr. Kirkpatrick and Dr. Miller and Dr. Moore. We'll go over why we measure, and then at the end we will do a worksheet session. So last week on CME, Game of CME, we covered these learning objectives. We talked about how do we identify a target audience for receiving the learning, and we looked at their parameters of profession and interprofessionalism, specialty that they practice in, as well as the geographical catchment area of those learners. We looked at measuring a gap for that audience, which is how we really drill down to a need, and we defined that as a difference between a desired state of practice and an actual or observed state of practice. And it can be along the axis of knowledge, the axis of competence, or the axis of performance. And by the way, there is an outline paper that you guys can use if you want to follow along and fill in, take notes on. It's got a lot of this lecture material with some blanks. We also compared evidence sources last week. Different types of evidence have different value. So we looked at the factor of generalizability of data sources, their relevance, and how current they are. We listed some common sources of evidence, expert sources, objective national databases, sources from your learners, such as surveys and feedback, And then objective local data sources such as institutional QI measures, and environmental scanning, which can be anything from the arrival of a new product or device on the market to the arrival of a new disease like Zika. And then there are many other sources as well. We related the principles of learner-centric needs assessment and interprofessionalism. So the sense of learner-centric are the needs expressed by your learners as opposed to, as Jack said earlier, by your faculty, your administration, or some other stakeholder. And a learner will have often an expressed need or an observed need. They may also have implied needs. I believe there was an old saying, when you don't know what you need to know, that's an implied need. And we define interprofessional learning as, or IPE as it's often called in the trade, whenever there's a student or a member of two or more professions learning side by side with each other, from each other, or about each other to improve collaboration and the quality of care. That's IPE. So today, we'd like to really focus mainly on the learning objective. And if you're building a house and that house is a continuing education activity, the ground plan or the architect's blueprints for that activity are your learning objectives. So let's talk about what that means to each of you. When we say the term learning objective, what pops into your mind?
What you hope to get out of it.
What you hope to get out of it? Thank you, good.
I was going to say, what you hope you convey to the audience so that they walk away with that information, understanding it.
Good. What they walk away with, sure. Anyone else?
Here's a real fundamental question. What does it mean to learn?
Build your knowledge, to build your knowledge base.
Build your knowledge base. You have to develop a skill. You have to change your beliefs to some extent. Right. So I'm thinking about learning. It's really, as I said earlier, it's focused on what the learner needs. And the learning objectives are a roadmap, a blueprint to help you get there.
And they can be, importantly, additive, so you're adding knowledge, or you can be changing knowledge, and as Jack said, changing attitude, changing beliefs and changing behaviors, replacing something that was formerly being practiced. So above all, and we've coined this term MAP, this is not a widely used term, we just made it up for this series really, measurable, achievable, and practical. I think those are really important so people don't feel that they're using their time in some abstract way, but that what they have will be applicable to a task in front of them. Many of you probably have heard the SMART acronym. I think it's very closely related to our MAP. Learning objectives, the best ones should be specific, they should be measurable, they should be achievable, but they should be relevant as well, and often they can be time-bound. So, if we are expecting a practice change to arise from a learning objective that we can measure, how long will we wait for that measurement? Will we wait 30 days, 60 days, 90 days, a year? Time-bound is important too in terms of when your result would express an outcome. So, does anyone have any questions about any of that so far? Okay.
Can I ask
Yeah.
you one question about time bound? Because we send surveys, I know it's different because it's a survey, it's not really an education, but if we send a survey out, and we're looking for a result at 3 months, a result at 6 months, and a result at 9 months, to see how has the information changed your lifestyle.
Mm-hmm.
You know what I mean? That's really the same thing. But how are you going to measure that time-bound piece? Are you going to send a follow-up survey? Say you have a CME. At the end of that CME, do you actually send a survey 6 months later or 3 months later?
You can,
Say,
yeah.
How was that?
Yeah, in fact, many education providers do exactly that, and they will often, I would say a minority of education providers will try to identify some sort of a practice change that the learner felt they would make either at exiting the activity or at 30 days, and then they'll follow up on that very thing and show the person their prior response and ask, did you change? Another measure that we used to use in my life before Winthrop, I was at a company that focused on continuing education, and we had a measure we called momentum of practice change. So we'd say, are you going to use this learning? And if so, will you use it within 1 to 3 days, 3 to 7 days, 7 to 10 days, 30 days? And then we would graph the response. So, if it's something that's immediately applicable, you'll see it within those 3 to 7 day buckets or later. And you can really graph how the immediacy of the impact by what people feel. And some of it's subjective, but at least you're able to get some data around that question of time bound. And, early on, your responses are probably a little more reliable. So there are definitely ways to do that.
That's a good segue into eventually we're going to get to Kirkpatrick and Moore's model, and touches on that very subject.
Yeah, the impact and the change. So Benjamin Bloom, in the 1950s, began really studying thinking, cognition, and he and his colleagues sort of identified 6 different levels. Knowledge and rote memorization, recall was really kind of the first basic level. Many school children practice this, memorizing multiplication tables through rote, things like that. Comprehension would be a level above that. So understanding, why, for example, there's a pattern in multiplying 9 times 1, 9 times 2, 9 times 3. The next level above that would be application, the correct use of facts, rules, ideas. These are all very familiar to all of us from our schooling. Application would be, can you take a method or perhaps a mathematical equation and plug in new variables and still get a result that you can rely on based on a rule. Analysis would be breaking down information, classifying things into component parts, understanding what pieces of a whole are. In the mathematical example, it could be solving for a polynomial that has more than one set of factors. Synthesis would be recombining those parts or recombining facts or ideas into a new whole. So using an analogy could be a way that you could synthesize if A then B, therefore if X then Y. And then evaluation is what Bloom considered the highest level, really forming an opinion about a situation or a phenomenon. And by the way, we will email you these slides so you don't have to slavishly write everything down, but we're going to move pretty quickly through some of this stuff. Now, Bloom felt that ideally there should be, each of these levels should be covered in any learning activity, and that you should write a learning objective for each level. However, we understand that sometimes, given scarce time and given scarce resources, you can't really do all the levels in a continuing education. Or in an interprofessional continuing education, you may need to emphasize common terrain that professions share rather than trying to hit 6 levels for every profession in an activity. But the idea that you can take people through a stepwise set of cognitive activities is an important one, because after all, most continuing education is not just recall of facts, but involves applying it to a new situation, applying what you learn to clinical practice. So Bloom's levels have attributes, and this is very much a restatement of the prior slide, but generally it describes boundaries between the levels, so that you can really orient yourself between if something is what I'm asking them to do really an application or is it an analysis. There may be some gray area, so you would want to use some of this framework to figure out exactly where you're at. And always, I believe higher levels are better if you can get your learners to credibly participate at these higher levels of cognition. That's better education. So we do have, and I think Jack's handout will give you a very comprehensive list of some of these verbs. But at each level, there are verbs that apply to that level. And this is where we begin to measure. So knowledge, simple verbs or simple keywords like who, what, why. Well, why may not be a knowledge question. Why may be more of an analysis question in some cases. But at each level, we do have keywords that, for example, compare, contrast, very different from build, choose, or combine under level 5. And the verb you choose in writing your learning objective, it's usually the very first word in the learning objective. It will imply how you intend to measure. It will imply what you intend to measure. And so we include this really as a reference for you. Does anyone have any questions on this framework? Okay. So let's go through some examples. So if we look at, say, the Earth's rotation, a knowledge question, recall, recognition of terms would, if with our measurable student outcome, would correspond to a measurement of asking the student, do you know when is the first day of spring? They either know correctly or incorrectly, or maybe they don't know. But that's a measurable outcome, what they know. At the comprehension level, you can ask them, well, can you explain the summer solstice? What does it represent? It's going to be a longer answer, but it is, again, measurable. Probably something you'll have to read, although it could be a multiple choice question as well. An application of that same example would be, what if? A what if question. What if the Earth was in a perfectly circular orbit? Would the seasons be different or the same as what we experience now in a non-circular orbit? At the analysis level, they're going to take that complex idea and maybe break it down and maybe flip it. So in our example, why are the seasons reversed in the southern hemisphere? Again, you can look at their answer, and if they came close to your rubric answer, that's something you can measure. Are people getting it or are they not getting it at the analysis level? And then at the synthesis level, the mental construction of ideas and concepts, forming something new, a new product, a new framework, is at the highest level. And an example of that would be, if the longest day of the year is in June, then why the counterintuitive result that we're hottest in August in the northern hemisphere? That's going to take a lot more information, synthesizing various explanations and laying it out to explain a theory or even evidence as to why we have those temperature variations that are non-intuitive or counterintuitive. And that's where we're really hitting the synthesis. It's more work for the student, it's more work for the teacher to grade, but then you really know if they got what was delivered. Any questions on any of those levels?
And you all know from your own experience too that looking at measuring facts, measuring basic knowledge, we do through multiple choice exam questions, right? Fill in the blank sort of thing, matching with just recall, basically that. Get to the higher order thinking skills. That's why we have here our simulation center upstairs. In medicine, we do OSCEs, which are performance exams with patients. A lot more difficult to measure, though there are ways of doing it, but you can see that or even having essay questions and having to read essays, if you've ever done that, that can be a challenge too for reliability, but then also too, you can see the gradients that go across this in terms of the outcomes.
Yeah. So that's a theoretical underpinning, but what about how do we know that what they've learned can translate into an achievable result in the clinic? What's achievable? A gentleman by the name of Kirkpatrick in the 90s posited a model that is 4 levels. This was immediately adopted, as you can imagine, by the corporate world, because in corporate training, they are concerned with outcomes as much as in healthcare, but maybe it's less scientific, maybe it's more behavioral in the corporate world. So these levels are very behavior oriented. Level 1, reaction. Well, did they like the training? Did they like the time we spent with them? Did they like the types of activities that we engaged them in? Was it boring or was it interesting? Those are level 1 outcomes. Did you have a good time? How was the food? Was the room too cold? Did we put you up in a good corporate hotel? Those sorts of things. Distinct from level 2, which is, what did you actually learn? Did you acquire any knowledge? Did you acquire any skills? Did we change your attitudes or your confidence level based on information and experiences we gave you in the learning? Did we change your commitment to the organization or to the situation that you're trying to learn about? Again, level 2 learning, according to Kirkpatrick. And then the behavior would be, you go back to the office or to the clinic, did you apply what you learned? And are you demonstrably behaving differently based on some correlation to today's learning? Level 4 would be sort of maybe an organizational view, looking at outcomes of teams, behavior change across whole organizations, or some sort of business metrics changing. And these are all great levels, these 4 levels, but really in healthcare, we started to think, it's not really enough detail. Miller came along in 1990 and said, well, it's not just knowledge, but there's awareness knowledge. There's knowing what to do, knowing how to do it. Some of the behavior is showing how to do it and actually doing it. So showing how in the classroom, doing it in the workplace, and then mastery would be, a level above that. So the more levels we have here, recognizes, knows how. Those are sort of level 2 for Kirkpatrick, but there are 3 separate levels in healthcare. Shows how it does, or sort of a refinement of Kirkpatrick's level 3, so we have more levels. Again, we can measure shows how and does separately, measure one in the clinic and one in the classroom. And then as people began to use this framework, we evolved. Don Moore from Tennessee said, well, I would really use 7 levels. And he grew out of Kirkpatrick and Miller, but he really began to look at our ultimate mission is to improve patient health and improve community health. So where that's somewhat present in Kirkpatrick's level 4, in Moore it's levels 6 and 7. So participant demographics at level 1 would be the sign-in sheet. How many people were actually in the seats? And where do they come from? What's their specialty? I think we have 4 or 5 different professions here, different levels of different areas of licensure. Level 2 would be, again, surveys and assessments, but not just did you like it, what did you like about it, or how can we improve it? What are your further needs? If you'll express those to us verbally, that's a level 2 Moore outcome. And then Moore said, well, level 3 knowledge is actually two kinds. Knows, which is considered declarative knowledge, and knows how, which is procedural knowledge. Those can be measured separately. Then there's also less easy to measure values, attitudes, and sort of value systems. But again, was knowledge transferred. Also, to be level 4, the shows how, competence. So a lot of certifications, for example, are very concerned with competence. Can you reproduce your competence in the classroom with a strong shows how activity, a measurable activity? Translating that into level 5, the performance Moore's level outcome, are you doing it? And to Christine's survey question earlier, one of the things that we frequently ask continuing education in a 30-day follow-up, or even in an exit same-day survey, will you change your performance in the clinical setting, or did you change your performance in the clinical setting? Again, very measurable, and increasingly any of the grant-making bodies, such as a pharmaceutical grant or a device company grant, even public health grant-making funds, want to see Moore's levels. They want to see what's the highest Moore level you're able to measure, what are you designing in for measures for your activity, and often the higher level of Moore you can manifest really impacts your competition for those grant dollars. So as you can imagine, CME, which traditionally has relied a lot on some of that commercial support, really began to pay attention when Don Moore published this framework, because it really did change how people think about resourcing for continuing education. Anyone have any questions or even examples they want to share?
So I'll give one example. We're all going, clinicians especially, with our electronic medical records called Sorian. You all know that we're doing this? Yes, indeed. And so as a consequence, you think about that. So there's training courses on how to navigate the system, how to use the system. So that certainly levels of knowledge, some levels of self-efficacy. You feel now confident that you can use the new EMRs when it comes into play. So, and then you get to the behavioral part. So putting it into practice, well, we're about to find out once it gets utilized. So that putting it into practice routinely, and that's the behavior part, the step 3 of Kirkpatrick. But the 4th level, and that's the ultimate one we think has a real impact, is how does this improve patient care? Okay. So you can look at that in many dynamics. It makes it more efficient for prescriptions, for record keeping, and those kind of things. Theoretically, that's good for the institution, right? So that's the highest level that we would get to. But that's going to take a while to be able to measure the outcomes there. So it's kind of that sequential process that works much the same way. So knowing a skill, having the self-confidence in being able to use that skill, but then putting it into practice routinely, and that's why doing a 6-month follow-up, it's self-reported data, but my gosh, you can't follow everybody around with a checklist to see if they're doing this, but even the self-reported gives you some level of confidence that you're actually measuring what you're doing. But what impact does it have on the system? Well, that's where the electronic medical records over time will tell us that.
Yeah, and that's a great example because it's institution-wide and will be aggregating a lot of data in the pretty near future. So I include this slide just so you'll have sort of a reference when we hand the slides out to you. This really explains it in detail, probably better than you can even read at this font size. But that's in there, and for further information, there are some reference links. So I want to get to the question of why do we even need to measure learning? And I'd like to open the floor up to any of you guys. Is there anything about learning that you crave to measure, or conversely, anything you wonder why we bother measuring?
In my arena, it would be the quality. of people.
Quality, good. Thank you, Diana.
In sports medicine, what kind of
Everything's changing, updates,
that's a comment.
keeping up to date with
Yeah.
what's new in medicine,
Mm-hmm.
pretty much.
And
As far as
prioritizing, yeah, but
surgeries
it's hard to prioritize because you can't, with all these changes going on, you have to be selective.
We measure a lot of, in oncology, we measure standards that through accreditation. So it's those accreditation, I guess, directives that we have to measure that we are meeting that
Accreditation of the center.
of the center.
And then also there
Right.
can be certifications of the personnel.
Right, so we have to measure those things to make sure that we're actually doing it. So I'll just give you an example. When a surgeon does a colon resection, they have to take out 12 lymph nodes. So there's evidence based on why they have to take out 12 or more. And if they don't take out 12 or more, why not? And, is that what you're talking about? So that's a standard that is handed to us.
Yes,
That we have to
absolutely.
follow.
That's a performance standard, absolutely.
It's a performance standard.
And that would correlate to an education standard, so
The
you teach the
education, right.
standard.
So the surgeon's education, so do you not know this? Were you taught this? Did you not retain it? Did you forget about it? Or,
Mhm.
so if it's not done, then we have to go all the way back and find out, okay, why wasn't it done? So.
Yeah, that's a good example. Any others? Okay. So one reason that at least we focus obsessively on this in my office, one reason we measure is because we need to make the most of scarce resources. And scarce resources, there's some obvious ones. Any ideas?
Money.
Yeah, money.
Time, space, money, and there's one more.
Availability, people.
Sure, yeah, that's part of time, but that's a good one. And I think, Dan, related to this one, goodwill.
Right.
If you waste a learner's time one time, why will they come back? So you want to make it, the goodwill can make or break you in the first few minutes of any education activity, whether it's a webcast, whether it's a live session like today. All of these are scarce because we all have so much competition for our attention and our time. We measure because we really want to be doing a good quality intervention. We don't want to be wasting people's time in a non-professional way. So that really gets to the question of aligning your learning objectives with the design of your course, which we'll kind of cover more in next week's session, design of the actual activities. But alignment is really the idea that are your learning objectives measurable? Do they align with actually measuring in an assessment? And are your activities that you chose or your instructional strategies actually teaching those things? So you have your objectives, your assessments, and your instructional strategies. They work together to help you cement and then measure the delivery of learning. what happens if they're not aligned? Well, students may feel that the test wasn't really what we learned, or we didn't learn some of the things that were on the test. So you really want to, not surprise people, especially if you're teaching people toward a professional certification exam. Very important to prepare them for what's really on that exam. And if you can get a hold of any of the people who wrote the exam questions as your instructors, or get a hold of their material, that can be a big advantage in giving people practice questions that are similar to what's on the test. We do have a session on test item writing later this summer that Jack will lead. Another aspect is that this instructor may feel, yes, we measured, but we didn't measure the right things. They're still not able to do, for example, the 12 lymph node colon resection. Just because they passed a test on it doesn't mean they've really mastered it. So that could point to a lack of alignment somewhere along the educational intervention. It also implies a learning contract, and as we consider the question of learning objectives, generally any sort of learning is planned learning. Generally, people are signing up in advance or signing up in reaction to some communication, seeing the learning objectives. If you don't give them what they signed up for, then it's not really, the most professional intervention. And so there really should be alignment between your intervention activities, your assessment, and what was promised in the learning objectives. The house you build should look like the blueprints that you started from. So, achievable and practical, do they matter? Cotter created a model about the 8 steps for change. Learning is not just theoretical, but you want to really create a climate for change by creating urgency, powerful coalitions in the case of institutions, and creating a real vision of why we're doing this. For example, Sorian, we need a better system, let's get one, and let's bring all the stakeholders we need to put that in place. IT designers, trainers, and the staff learning themselves. Then you want to engage and enable the organization by communicating the vision, empowering the action, and importantly, quick wins. Other people call this low-hanging fruit. If people don't walk away with a sense of winning for their time, that's probably not going to have the best feedback for your course. And then you want to implement and sustain for the long haul. So you want to build on the change and make it stick. This framework, Cotter's 8 steps, is actually used in a lot of places. It started out in business, but it's really used in any sort of PDSA driven work, such as software engineering, building of things like Sorian, building health apps, but also teams and interprofessional learning. If you have to change a way that a clinical setting operates with a new protocol, you really need to look at some of these 8-step frameworks. So I will hand things over to Jack for the worksheet session now.
What we try to do with this is to use what we call kind of a flipped classroom model. So we sent out some free reading for you to hopefully get you jump started, and if you've had a chance to do that. And we're all friends here, so if you didn't, I have an actual copy of it. And I asked you to look at, and these are live in vivo learning objectives that I've taken from some of our CME related programs. So you've had a chance to look at them. I had a little foot surgery, so I'm going to kind of lean on things a little bit here. Anyway, so what do you see about these learning objectives? I'll give you the course title, but it doesn't really matter. So, be able to understand something. How measurable can that be?
Well, you can't measure that
Oh, there you go.
unless you
Well,
give them some kind of a test that measures their understanding
well, we don't even
level?
know what understanding is.
You
so
know what I
We'll,
mean?
we'll get to that. How about the second one there? Be able to review the changes. Well, you might be able to do that.
Test.
Right, so the second one probably has the most value, number B. Number C, once again, to understand, to know, what it means to know. How do you ever put this all? That's too amorphous, for sure, right? Or to learn. Christine learns. You got to break that down into two. So we're looking at Bloom's taxonomy certainly is a way to be able to make that more measurable, because that's not really. And then the very last one there that I gave you is the sleep apnea one.
I think you can measure that.
Well, but nothing is there. It says, it's a statement.
Yeah.
It's an in-depth insight. No, but they're fine. No, that's not a learning objective. This really says nothing. The systematic, so none of that is a learning objective. So the whole point here, what I want you to do is be able to look at these and say, and critique them. And I know you've seen these before in your own world. So this is really an opportunity then for us. We can go into the worksheet. Is this a good time now?
Absolutely, yeah. I'm looking at it on my phone. I'm not checking email or
No.
I don't have a printout, so I'm
Good.
watching it on my. I'm looking at it on my phone.
So this is, having done this many years, many times, this is actually a worksheet that you can do, and I want you to work in here, so Christopher, get a chance to do this. So you do it individually and then collectively. So it works like this. So as Rob indicated, I've given you a plethora of verbs that you can ever use. So I'll put that in, might be somewhat helpful. What I'd like for you to do is to think of a course, theoretical course, doesn't have to be a real one, doesn't really matter, you can make one up, that you want to teach, and this is what the worksheet is for. So you'll notice here, so I want you to do this individually. Give you about 2 or 3 minutes, doesn't take much, but still, be able to do that. So think of a particular topic. So it could be something on, say, a topic maybe on sepsis, something. So what are your learning objectives to meet the needs of the learner? So and you'll notice that I've included, like I said, copious examples of verbs that you could use at each level of Bloom's taxonomy. So
Do it separately and then
do it individually,
compare
and
your-
then you'll pair up and share with each other.
Okay.
You know, one of the real challenges we have, and Rob didn't really mention it directly, but you know, we have multiple learners, right? So at different levels. So you may have nurse practitioner and a cardiovascular surgeon in the same. So when you're writing learning objectives, is that a challenge? You've got multiple learners, you know? I mean, so cardiovascular surgeon certainly knows much more than perhaps a nurse practitioner would. You would expect that. So is he going to need, so think about your audience, but that's kind of a separate concern, but still one that's fine.
And if it's too daunting to think of the group, maybe just think about your own learning needs.
Yeah, so
and
think
think
of
yourself
what-
as an N of one.
Think of a coherent.
I've always wished I could better X, Y, Z.
And using Bloom's taxonomy, it could be all, if you wish, here, it could be all at the knowledge level if you wish.
Yeah.
Or you could have the knowledge and maybe 1 comprehension or 2 comprehension. Obviously, these are for you to keep, so you don't have to hand them in, so if your writing is not clear, as long as you understand. You get a chance to share with your partner and we'll discuss. So using a think, pair, share as a way to kind of build knowledge collectively, maybe in the interest of time, just get your own perspectives on what you might have as a learning objective. So, either of you want to perhaps share your perspective?
I'll try to.
Okay, if you don't want, if you don't want,
No.
go ahead. What's the course title, or what's the topic of the course?
Well, I was going to go with breast cancer,
Fine, sure.
and I don't know if this is, but I'm going to try it anyway. Identify the factors associated with breast cancer.
Perhaps risk factors, maybe.
Yeah.
It's a possibility, right? Good point. What's another one?
And since there's so many different procedures, and all, like I would say, understand the components.
Nope, ain't gonna work.
Sorry?
The word understand is a red flag.
Can't measure it.
Describe.
Um,
Describe works.
Or
recognize. How about
Oh,
recognize?
that sounds like a good one too. So given a couple of practice standards, which one is most applicable or something?
And Peter, do you know what level your first one was? What would you call that? What level?
That would probably be level 2. Level 2 or level. Because level 1's just like science, as you said, like science. It's not. Is it?
Well, a list of risk factors, if we're asking them to memorize that and then measuring whether they did memorize that, I think that's kind of a knowledge question. It does approach comprehension, I suppose.
Basic knowledge.
I didn't want to go. I wasn't going above maybe level 2.
What?
Yeah. Christine, what did you have?
My topic was compassion fatigue. And my number one question I took from the knowledge
Good.
area, I wrote identify the signs and symptoms of physical and emotional, that are physical and emotional for compassion fatigue.
I think that sounds good.
And for number 2, I took from the comprehension, describe what resources there are to address compassion.
Excellent.
Number 3, I took from, I went, 1, 2, 3, 4, application, apply strategies to combat compassion fatigue. And number 4, I wrote categorize different levels of fatigue.
If I can go one step higher, you might have somebody maybe able to write a patient care plan or individualized plan for one to cope with something.
So would those be my teaching strategies?
Well, I think that's perfect, if that's what you're going to teach. So yeah, so that's built into the curriculum, so that becomes a part of your curriculum. So all the things that you could do in like a 1 hour, right?
Mhm.
Okay. So at the end, you can actually have a quiz. You can actually measure some of this. Right? So you know that you've actually got.
And in the apply strategies for combating that could be a sim center, it could be a role play in the classroom.
I mean, what we do for that is we, meditation strategies, meditation, deep breathing, visualization, relaxation techniques, what is that called? When they tap your face, I can't think of the name of it off the top of my head, but it's another relaxation strategy. But okay.
Dan, how about you, Richard?
I have ACL tears in youth sports. So first one I have is identify risk factors predisposing females to ACL tears compared to males. So females are more prone to ACL tears compared to males because of their body composition. And then the second one I have was give examples of rehab and strength training exercises to reduce ACL tears in female athletes.
So if we were to challenge you to say upgrade your first one from a level 1 knowledge base to more of a comprehension base, how would you go about doing that?
Well, I know identify and recognize are both in the same category, but would recognize be different to use? Would that put that at a higher level?
That's pretty more of a comprehension, I would think.
Yeah. And maybe if there's any data as to why the genders differ, explain the mechanism, whether it's genetic, hormonal, whatever.
Or analyze data,
Yeah, there you go.
Yeah.
analyze statistics predisposing females to ACL tears compared to males.
Mm-hmm.
But one strategy that you might use the oftentimes is having a case study. So at the end, you might have a case study of a young athlete who's presenting with these signs and symptoms and this whatnot. What would you do? So that's pretty high order stuff. So what would you do? You get imaging, I'm sure, or something. But still, whatever the process is, get a consult. So putting the pieces together to actually solve the problem.
Yeah. Diana, what did you do?
Ectopic pregnancy.
Mhm.
Identify normal versus abnormal IUD, which is injury pregnancy. Recognize the importance of observing abnormal implantation. I use a word that's not here, but optimize scanning techniques to optimize diagnosis strategy.
How do you measure optimism?
This is always something
A
better.
tough one, yeah, that's going to be. So you might have a ranked order that the evidence says, this is level 1, level 2, level 3. So optimizing would be the highest. How does that really? I'm trying to reach to something. But you could assess and appraise. That might work.
You could also, if you're showing people a procedure in the education, you could
Yeah,
have
I was
them
thinking
demonstrate
Yeah.
back to you, reproduce, demonstrate. If there's a best practice, can they actually show you? Remember that knows how shows have. That's measurable. Did they do it? Did they deviate? And optimize isn't a bad word. It's just not a good verb. So you could say demonstrate optimal settings or
Yeah, given a set of standards, because it would have to be with some standards, otherwise you can do it but it's the highest order. Because optimizing to me implies some kind of hierarchy, right?
Yes.
So these are, I think, ways where you can. So the importance for learning objectives is not so much for the learner. It actually helps you too, doesn't it? Because like in a 1-hour session, teaching session, these are the 4, if you have 4, learning. These are the 4 things that you have to teach a million other things, but these are the 4, or 3, whatever it is. So how am I going to be able to do that in this upcoming session to be able to think? What are the methods that I can use to effectively make use of time so it's learner-centered? Certainly active learning would fall in that category. But using these learning objectives as a guide for instruction, and also it tells the learner what? It tells the learner this is what's important. These are the things we're going to cover.
Last questions?
Well, I have a question.
Yes.
So when I go to submit my CME application for my program, the learning objectives, should I then do exactly what I did now, is follow that Bloom's and try to pick an objective from number, level 1, a knowledge, a comprehension. Should I do that? You
It's
think
not
really
required for
would
accreditation,
make the
but
audience think a little bit?
yes, your house is only as good as your blueprints. So if you start with, really good Bloom's measurable verbs, things will just sort of follow logically, and it will fall together. Yeah. A lot of thank you, Jack. Oh, I thought you were leaving. A lot of continuing ed is more of a smorgasbord approach, not planned learning. And I would refer you guys all to, Jack has an excellent module on our InReach system about designing around gaps, but also around sequencing. So that sense of getting to all the levels may happen in more than one
Only
session.
about 8 minutes. So anyhow, it's a voiceover on the slides, and it kind of reinforces the numbers. So you'll find in your educational.
Is that on Saba?
No, winthrop.inreachce.com, that link. You can also scan that with your phone, and it'll.
This will make it more satisfying than instructor too. I gotta tell you that. Focuses your teaching and learning on specific measurable outcomes. Because like I said, in an hour there's a lot that you could cover, but what's really important that you want to get across, the learners know that they're going to do. And it'll help motivate them too.
Yeah. So just want to give a plug for next week's session, Learning Modes, Styles, and Preferences of the Adult Professional. Will they retain it? Next week, same room, same time, same place, same cast of characters. I hope you will all join us.
Can you,
Are the dates different on it?
the dates?
Oh, yes, we did. Good catch, Diana. We moved all the dates forward one week. So forgive me.
And actually, the room is the next room over.
Yeah, the rooms move forward with the dates. Good catch. I will correct that before I send it back out to
If
you.
if you send papers out, can you send them earlier in the day? Because I think I
Yes,
just came
that's-
to my email, it was after
absolutely.
I was already gone, so I didn't find it. I didn't get it until like 10 o'clock this morning.
Absolutely. Good feedback. Thank you. And I'll be sending you a survey later today on this course, and you'll be able to get your certificate of completion at the end of today. So thank you all for coming.
Thank you.